Dr. Pevec doesn't need any introduction as our Chief of Vascular Surgery, going to lecture on the contemporary management of patients with ruptured AAAs.
Thank you, Dr. Bold. Maybe not as much fun as some of our more recent topics. I have no disclosures. So traditionally, Grand Rounds to start with a case presentation, so we're going to be traditional. This is a 58-year-old man who presented from the referring hospital with abdominal pain in June 2012. I actually met him in 2009, which time he had an infrarenal aortic aneurysm 61 millimeters in diameter. I actually recommended elective repair as prophylaxis against rupture. He was of an ethnic group that has some hesitancy to accept Western medicine, so he was going to go back and speak with his community elders. Never saw him again until 3 years later when he came back with a rupture. He was obtunded with a heart rate in the 60s and systolic blood pressure 120. He had a tender pulsatile aortic aneurysm, and he was sent for an urgent CT scan to assess his anatomy. And this scan shows a large infrarenal aortic aneurysm. You can see significant surrounding blood in the retroperitoneum. This is a coronal image showing that hematoma around the large aneurysm, and a sagittal image showing the hematoma associated with the aneurysm. So he was taken directly to OR 45 from the CT scanner, had an endovascular aortic aneurysm repair done under local anesthesia with sedation. This is a intraoperative arteriogram showing the metallic components of the endograft, intraoperative arteriogram showing the exclusion of the aneurysm by the endograft. He was discharged home on postoperative day number 8, tolerating a regular diet and walking independently. This is his 1-month CT scan showing total exclusion of the aneurysm with good placement of the endograft. This is an endograft with uncovered suprarenal components, so you do see some metal above the renal arteries, but there's still flow in both renal arteries. The distal landing zones are right at the company-like bifurcations as intended, and this is just other images of his completion repair with no sign of endoleak. Just for follow-up, he came back 3 years later in February 2015, at which time, actually 2.5 years later, he'd actually had retraction of the right graft iliac limb into the aortic aneurysm sac and had a distal endoleak. That was revised with an endovascular replacement of an additional iliac component. And 6 months later, 3 months after the original rupture, he was still doing well. So just for a break, I can get away with this is a Catholic joke, and being a Catholic, I've got the card to be able to offend people on this one. So a man suffered a major STMI, underwent extensive percutaneous coronary intervention. He awakened in a Catholic hospital. The nun questions, how is he going to pay his bill? She says, do you have health insurance? The man says, no health insurance. Do you have money in the bank? The sister asks. No money, the patient replies. Do you have a relative who can help settle the bill? The nun asks, growing impatient. I have only a spinster sister who is a nun, the man replies. The nun becomes indignant and states, nuns are not spinsters, they are married to God. To which the man replies, then send the bill to my brother-in-law. So ruptured aortic aneurysms are associated with about 15,000 deaths per year in this country. It's the 10th leading cause of death in men over age 55. Overall mortality, if you rupture your aneurysm, about 90% of people die because most don't even reach the hospital for intervention. However, it actually looks like it's worth intervening on these patients. This is a slide looking at patients who have ruptured aneurysms. You can see there's a big drop-off. This is an old slide, and there's about a 40% upfront mortality, but beyond that, patients' survival curve actually paralyzed that of age and gender matched controls. So it is worth trying to repair ruptured aneurysms because if you get the patient through the operation, their prognosis actually is favorable. But the problem is, this is a problem that's been around for a while, and we didn't show a whole lot of progress. So the University of British Columbia reported their series over 4 decades, 1955, which is around the time the first aortic aneurysms were repaired, up until 1993. And they saw that operative mortality dropped from 54 to 44%. Not a whole lot of improvement. And in fact, it was not even statistically significant. The meta-analysis, looking at the same 4 decades, showed that there was a gradual 3.5% reduction of mortality per decade, but still by 2000 was still 41%. So basically, over the first 4 decades of the history of treating this disorder, we didn't make any progress. But then in September 1999, the FDA approved the first endografts for aortic aneurysm repair for elective repair, and the paradigm started to shift. So just to get everybody to understand what this means, what an endovascular repair is, instead of the traditional approach where the abdomen is open or the retroperitoneum is open to expose the aorta, clamp the aorta, and directly replace the aorta is exposed from a remote source from the groins, typically now done with just punctures in the groins or can be done with small incisions. And then a rather large diameter catheter is inserted through the femoral arteries, and on that inside that catheter is a fabric graft. Most of the designs are actually a bifurcated graft or a pair of pants. It's a fabric graft with a self-expanding metal in the wall, and then that graft is deployed for an infrarenal aortic aneurysm to seat the graft in the aorta, proximal to the aneurysm, inferior to the renal arteries, and then graft limbs are deployed into the iliac arteries, and basically the aneurysm is excluded from the circulation. The blood flow goes through the endograft, and the aneurysm, although still there, is not in direct contact with the circulation. And again, it's a radiograph of the patient we showed earlier. This is just an actual image of an endograft in place. And this is a review of the national inpatient sampling. So it's a 20% sampling of hospital admissions in the United States looking at repair of ruptured aortic aneurysms from 2000, the year after endografts were first introduced, up until 2010. You can see there's pretty quick adoption of this for rupture. So in 2000, the first year these grafts were available, a small number of patients had endovascular approach for a ruptured aneurysm. But by 2010, it was approximately about a third of aneurysms were treated by endovascular technique. And this same study suggests that there was improved survival for patients with ruptured aneurysm undergoing endovascular repair. And this is just a tabular form from that showing that in 2000, when this was first tried, the mortality was still about 40% for both open and endovascular repair. But once experience was gained, about 20% mortality with endovascular repair versus 33% for open, suggesting that there may be something to this. However, that's just a series of discharge data, basically, not a very carefully controlled trial. The only randomized data to date is the so-called IMPROVE trial, which was conducted in Great Britain, published in 2014. And in this study, patients who presented with ruptured aortic aneurysm were randomized to either open or endovascular repair, and they found actually there was no significant difference in mortality between open repair, 39%, and endovascular repair, 36%. So questions some of the other observational data on whether the endovascular repair really is superior for survival. There's been some efforts suggesting that having an algorithmic approach to the repair of ruptured aortic aneurysms can be helpful. This is from the University of Washington group, one of the first groups to set up such a protocol. They've got a very sophisticated pre-hospital care system in Seattle, and basically virtually all the ruptured aortic aneurysms in Seattle go to Harborview Hospital in Seattle. And this is a publication of their experience from 2010. So if the patients were hemodynamically stable and mentating, and the blood pressure was at least 80, they went to have a CT scan. If they were unstable or hypotensive, they went directly to the operating room. From the CT scanner, the patients then went to the operating room. The patients were prepared while they were awake. They were allowed to be maintain a blood pressure only about 80. Sheaths were placed in the groins, and then if the anatomy was favorable, they had an endovascular repair. If the anatomy was unfavorable, they had a balloon inserted in the aorta to control the aneurysm, and then they were progressed to open repair. And what they found just in the first year after starting this protocol, their mortality dropped from 58% to 35%. So dramatic improvement just by initiating a treatment protocol. And what they found when they looked at their data is the dark rectangles are the open repairs. There was no improvement in mortality with the protocol for open repairs. All of the improved mortality happened from improvement in the mortality for the endovascular repair from before to after protocol initiation. A more recent study looking at the same thing, the advantage of a protocol, this comes from our colleagues at Stanford and just published last year. And it's virtually an identical protocol. Basically, patients come in, if they were stable enough, they got a CT scan, they were prepared to wake, they had sheath placed in the groin, had a balloon placed, and if they had adequate anatomy, they underwent endovascular repair. Inadequate anatomy, had an open repair. And what they found, contrary to the Seattle group, is that the group at Stanford found an improvement in mortality after the protocol for both open repair. Prior to protocol, 35% mortality. After the protocol, 14% mortality for open repair, which is remarkable. And likewise, I saw an improvement in mortality for endovascular repair, 50% before protocol initiation, 18% after protocol initiation. And overall mortality dropped from 37% to 17%, all comers. So both these series suggest having a protocol helps, and the reasons why it helps may not be quite as clear. So based on this, we asked Kay Bean, who's here in the audience today, to help us develop a protocol, and we actually have a protocol in place now where if there is high suspicion for ruptured aortic aneurysm in the emergency department, the patients immediately get a quick ultrasound to confirm the presence of an aneurysm. You can't usually diagnose rupture, but you can see, is there an aneurysm there? If the patient has an appropriate clinical scenario and has an aneurysm, they go directly to the CT scan. The emergency department actually notifies the operating room as the patient's rolling to the CT scan and contacts the vascular surgeons, and then the patient is taken directly to the imaging operating room. We allow permissive hypotension, which means we do not resuscitate the patient unless they are unconscious or their systolic blood pressure is less than 80. They're given moderate sedation, and the procedure is started under local anesthesia with groin punctures, and a balloon is inserted for occlusion if needed. So this is some pictures showing what I mean by a percutaneous approach. So it turns out that there are devices that can be placed through a needle puncture, and through that device, needles are brought from the inside of the artery back out through the skin, and a looped suture is put through, and you actually place two of these sutures first. You can put a small sheath through that opening, then you can actually dilate up to a larger sheath so sutures move out with the sheaths, and when you get done, the patient's left with this kind of incision to fix the ruptured aortic aneurysm, different than the old paradigm. This is the balloon occlusion concept, so we talk about that. We get to the patients to the operating room under local anesthesia. We access the groins, we put a balloon in. So the balloon is a compliant balloon, so you insert a stiff wire up into the aorta, take a long sheath to help support that balloon, and that balloon is placed under fluoroscopic guidance into the aorta proximal to the aneurysm, and this is just a fluoroscopic image of an inflated balloon in the aorta to control a ruptured aortic aneurysm. So the protocol is we either do the continue and complete the endovascular repair under local anesthesia, or we can convert to general anesthesia. We have that balloon inclusion in place, which greatly seems to improve the outcome for the open repair, because when you open the abdomen, the aorta is already controlled. You don't release all that bleeding when you release the tamponade. Again, you can do an open repair if needed, and we don't vigorously resuscitate until after the aorta is controlled, either with a balloon or with a clamp. Permissive hypotension is one of the concepts that is currently accepted for management of ruptured aneurysms without a whole lot of data to support it. So what does permissive hypotension means? It's understood by most of the audience because this is used in penetrating trauma quite a bit. And in blunt trauma, you minimize resuscitation to just maintain consciousness, to avoid myocardial ischemia, and keep the systolic blood pressure about 70 or 80. There's a consensus supporting this. There's no strong data. In fact, the only paper I could find looking at this for ruptured aneurysms is a paper published back in 2007. Completely uncontrolled. This is just a report of their protocol to limit pre-hospital fluid to 500 milliliters and accept the systolic blood pressure of 50 to 100 millimeters of mercury after admission. 77 patients, 53 had open repair and 24 had endovascular repair. About a third of the patients had uncontrolled hypotension, about half had hypotension per their protocol, and they showed the mortality was similar to what others have reported, 49% for open and 25% for EVAR. Is it any better? You can't tell. Is it any worse? You really can't tell. It's the only paper I could find even addressing the question. But it seems to have been accepted. The improved trialists, a group from Britain, actually have questioned the wisdom of permissive hypotension. This is a post hoc analysis from their trial where they looked at survival in relation to blood pressure. And this are the recorded lowest blood pressure for the patients. And you can see I'm sorry, I keep hitting the wrong button. You can see as the blood pressure gets lower, the mortality gets higher. And that seemed to be the patients who had a systolic blood pressure greater than 100 seemed to do better than the patients with systolic blood pressure less than 100. That probably has nothing to do with the protocol. Patients with less hypotension, you'd expect to have less severe physiologic insults. You can't really say a whole lot from that, but the author of this paper actually concluded that perhaps the 70, 80 millimeter mercury threshold for permissive hypotension might be too low. That question is completely unanswered. What about the question of using local anesthesia? That's been accepted in our protocol. There actually is an extensive experience of using local anesthesia for elective endovascular aneurysm repair. This is the largest series I could find of 1,150 patients undergoing percutaneous endovascular repair at a single center. 80% were done with local anesthesia and sedation alone. 94 of the percutaneous access was successful. 6% required surgical repair. Mortality was 0.6%, so suggesting that it can be done safely, at least for elective endovascular repair in a large series. And this is a analysis of cardiac complications of patients undergoing endovascular repair under local anesthesia. And what they found was that compared to general anesthesia, overall cardiac events were significantly lower, 5% in the local group versus 13% in the general group. And if they dropped troponin release and only looked at cardiac death, MI, congestive heart failure, or arrhythmias, there was only 0.8% of those significant cardiac events with local anesthesia versus 6% with general, suggesting that there may be some advantage, at least in the elective population, to use local anesthesia for endovascular aneurysm repair. And then this is just a large meta-analysis looking at local versus general anesthesia, again for patients with elective endovascular repair, 13,000 patients. Showed no significant advantage from mortality, but did show that local regional anesthesia had an advantage in terms of operation time, hospital length of stay, and overall complications. So it suggested there was an advantage, at least in the elective population, to use local anesthesia. However, there is a downside, and this is from an abstract of a paper discussing endovascular repair, and what the authors state is the use of local anesthesia can impact imaging quality and thus precise endograft placement, which should be considered in patients with challenging aneurysm morphologies. So basically what they're saying is if the patient's moving or breathing, it can be much harder to land that graft exactly where you want to land it. This is potentially a very big problem in patients with ruptures because those patients tend to be hypoperfused. They tend to get quite confused and agitated. And if the patient's moving around, you cannot really safely do the endovascular repair. So there are real disadvantages, even though there seem to be cardiac advantages, length of stay advantages, maybe survival advantages of local repair. You have to think about it because it can make the operation more technically difficult and can lead to problems. I was able to find a meta-analysis looking at the question of local versus general anesthesia actually just for patients with endovascular repair for rupture. They found no difference. So this is mortality on the y-axis and percentage of patients getting local anesthesia. And you can see the line is basically flat, the correlation line. So they're really, based on this meta-analysis, no significant advantage of local versus general anesthesia for patients undergoing endovascular repair of ruptured aortic aneurysm. However, going back to the best data we have, the IMPROVE trial from 2014, they did a post hoc analysis. Patients were not randomized by anesthetic technique, but on post hoc analysis, there was a significantly lower mortality in patients that had local anesthesia versus general anesthesia with an odds ratio of under 0.3. However, one can assume that the patients that had local anesthesia probably were selected to be better patients in better condition. So you have to take that with a grain of salt. Even though it comes from the best data, it probably was a significant selection bias. How about transfusion management? We are pretty convinced for the trauma patients that using a significant clotting factors along with red blood cells decreases the risk of mortality and bad outcomes, and that seems to be the case with ruptured aortic aneurysms also. Mortality seems to be decreased based on a couple trials when you have a high ratio of FFP to red blood cells. Autotransfusion also seems to be helpful. The top studies from the University of Utah, a rather disreputable vascular program, University of Utah, where they looked at patients had more autotransfused cells than bank cells, and mortality was actually lower than if they had more bank cells than autotransfused cells. However, another study showed that, interestingly, even if you use autotransfusion, it doesn't seem to decrease the total number of banked red blood cell units transfused. Traditionally, when patients have a open ruptured aortic aneurysm repair, they do not get heparin out of concern that they're already going to be fibrinolytic and coagulopathic. It turns out, based on this study reported in 2008 of patients with ruptured aortic aneurysm, these are open repairs, that actually the use of heparin decreased mortality versus use of no heparin. I found this interesting. Actually, this has changed my practice. I have started to use heparin even on open ruptures based on this, and I've not seen that it actually causes a problem. If you don't use heparin, you sometimes are occasionally faced with problems with thrombus in the iliac and femoral arteries, which is very difficult. Activated factor 7 for intractable bleeding is something that's been looked at also. This is a study looking at patients who had refractory hemorrhage either after ruptured aortic aneurysm repair or elective repair of thoracoabdominal aortic aneurysms. And about half the patients received recombinant activated factor 7, and then they had control patients. And they found the mortality was actually substantially reduced with the use of recombinant activated factor 7 for intractable bleeding. So that's another adjunct that can be considered in the management of the patient with ruptured aortic aneurysm. And basically, the last concept we're going to talk about is the abdominal compartment syndrome. So as you all know, compartment syndrome is when the intra-abdominal pressure is elevated such that it leads to compressive problems, which can decrease the ability for gas exchange in the lungs, can decrease renal function, can cause problems with venous return. And this is a problem in patients who have ruptured aneurysms due to the space-occupying effect of the retroperitoneal hematoma. One would think that this would be more common in the endovascular patients because they don't get a coelotomy, they don't get that hematoma released at all. But it turns out from the largest experience I could find published this year from Sweden. So Sweden has a vascular registry. Basically every patient in Sweden who gets a blood vessel operation gets recorded into a national registry. So they follow their patients nationally quite closely who are getting vascular repair. And they found the compartment syndrome was actually, the incidence was about 7% in both open and endovascular repair, so very similar. And this paper, they did not specifically look at outcomes stratified, whether it was open or endovascular, but what they did find is getting the abdominal compartment syndrome is a bad predictor. So the blue line is patients who did not get the compartment syndrome, survival of about 80%, versus ones who got compartment syndrome, survival more like 40%. So getting the abdominal compartment syndrome is a predictor of poor outcome. So in summary, the current recommendations for management of patients with ruptured aneurysm of the abdominal aorta is have a protocol based on the experience from both Seattle and Stanford. Just the presence of a protocol seems to improve results. It gets your whole staff focused on the problem and the timely management of these patients. It's consensus to resuscitate gently. Do not vigorously resuscitate with volume until the aortic rupture is controlled. There are not good data to support that, but it seems to make sense. We recommend starting with local anesthesia. The just induction of general anesthesia frequently leads to loss of sympathetic tone. In patients with ruptured aneurysms, they frequently will have a rapid demise as soon as anesthesia is induced. So local anesthesia for the rupture seems to be a good idea. Under local anesthesia, you can then percutaneously insert a balloon for control of the ruptured aorta prior to intervention, whether it's going to be open or endovascular. If you can do endovascular, it seems that the results are better. That's certainly our anecdotal experience. From my perspective, an endovascular repair is much better tolerated than open repair. But once you have the balloon in, you can do either the open or the endovascular repair. And then resuscitation is begun after the aortic leak is controlled. Probably advisable to use heparin, whether doing open or endovascular repair. Probably advisable to use the autotransfuser, particularly for open repairs. Probably not as advantageous for endovascular repair. If the patients are requiring significant blood transfusions, which virtually all of these patients do, FFP and platelets should be given at a high ratio very early on in the resuscitation to avoid coagulopathy. And if the patient develops coagulopathy, activated factor 7 is probably helpful. That's all I have. I'm open for questions. Thanks. Dr. David.
Can you go into more detail about the implementation of your protocol? How did you go about educating staff other than your staff in vascular surgery?
I don't know if Kay wants to take that one, but we immediately got the operating room, cath lab, emergency department involved with development of the protocol. We actually gave a very similar presentation to the emergency department, the anesthesiologists, and the operating room staff. Multiple meetings with all those folks, and what was very helpful, we had a couple of mock, if you will, ruptured aneurysm patients come through. So actually we did walkthroughs with the patient all the way from intake in the emergency department all the way to the operating room, to the point of prepping and draping, having all the instruments ready. And the couple patients we've had since the protocol was initiated actually have gone almost too fast. So it's actually almost frightening. The patient we're just kind of walking in the hospital, the patient's got their scan on the OR, in the OR table, ready to go with the anesthesiologist, nurse, and wondering where the heck we are. So it's pretty impressive. Kay, do you want to make any comments?
No, I think it was a huge collaborative effort among disciplines and departments to get it off the ground. Including ED and anesthesia. We started with the emergency department, trying to get an understanding of what it was they needed on the front end in order to triage the patient, both nurse names and the physicians, and then the collaboration started with the surgeon on the emergency department. And from there, rolling it out to the main OR and the cardiac cath lab. And both teams need to be present in the operating room for this procedure. It also included this integrated care, so that once the algorithm actually finalized, which took a while, I think we started the process in August 2014 and actually had our first dry run about a year later. And then the second dry run in December of the year. So I think the dry run and utilizing the sensitive care and having the dummy patient and doing the walkthroughs was really helpful. The first dry run actually was really helpful because it identified a number of gaps in the process of care. It also included nursing in the ED, nursing in the OR, and even radiology. Patients who come to the outside of the skin so that the surgeon would have more understanding. So it's a big collaborative effort, I think, and just trying to get an understanding of what everybody involved in the process to be efficient and effective.
Draft?
So the mortality for compartment syndrome, Bill, do you think that's a marker for mesenteric ischemia, or what is it?
That's a hard question to answer. I think it's a marker for greater physiologic insult. So when you take care of these patients, particularly when you do the endovascular repair, some of these patients act like an elective repair. So they've had a rupture, but the next day they look fine. They're home in a couple days or a few days without a hitch. Other patients, even with endovascular repair, look like you just did an open repair, and they are really, really sick. So I think it all has to do with the degree of ischemia and reperfusion, and the compartment syndrome increases the ischemia and also adds pulmonary dysfunction and renal dysfunction on top of that. So I think it's a whole systemic inflammatory response, multi-system damage, and the compartment syndrome both contributes to that, and it's a marker of greater blood loss. So I think it's a marker of the patients having a much bigger problem to start with, and it in and of itself compounds the problem. So big blood loss, big transfusion makes you sick. Being more in shock for longer makes you sick. Being reperfused after being in shock makes you sick. Having your diaphragm pushed up, so increased ventilatory pressures, makes you sick. Renal dysfunction, as we all know, is a huge predictor for poor outcomes. So I think it all goes together. It's a marker and an add insult both. Mike?
I Great talk. When you were talking about Dr. Schnarr's studies, and you talked about implementing your own protocol, you think about the next step. And it seems like really probably the next big game could potentially be from the pre-hospital care. And I know that's something Dr. Schnarr's working on in the past. How do these protocols launch then into the pre-hospital care as far as getting the patients to a specialized center quickly, permissive hypotension?
Well, yeah, Dr. Starnes pointed out that the big thing he asked his pre-hospital providers is to do nothing, basically scoop and run. He did not want to put in IVs, didn't want them doing anything. Just get the patient. So if they thought the patient had a ruptured aneurysm, just get them into the hospital. And that's basically all he's asked for the pre-hospital protocol. The advantage that he has in that program is it is a very region-wide organized pre-hospital care system. I think it all started with their management of myocardial infarctions, which Seattle was the first place to really implement bystander defibrillation and so on. And they very organized as a regional pre-hospital care that they're able to funnel those patients directly into the Harborview Hospital. So that's something that's harder to do in many other environments. We do not have, as far as I can find out, as cohesive an organization for our pre-hospital care. And that's probably the best thing that's going to happen for ruptured aortic aneurysms if they can be regionalized. That's been shown in some studies that patients actually going to a center that's equipped to do endovascular repair and has a decent volume of aortic work, patients do better than being cared for locally. So some of that is self-predicting. If you have a rupture and you can survive an ambulance ride, you've already selected yourself out as being in the higher survival group. So there's some uncertainty whether regionalization is really the answer, whether you're just cherry-picking the patients who can survive long enough to get there. But that being said, probably most patients will do better if they can go to a specialized center. But how you organize that is the local politics are a challenge. So, Ian?
I had a question about the heparin and what people think is giving you the survival advantage there. Is it something obvious or is it something more subtle?
I don't know if it's the question is why heparin seems to be advantageous. Dr. Blaisdell would always point out that heparin actually is an anti-inflammatory also. And those of us who went to medical school will remember that the clotting cascade initiates the inflammatory cascade also. So it may be a positive inflammatory, anti-inflammatory effect. I don't know if that's true. I don't know that that's actually been specifically studied. It turns out that if you don't give heparin, the clotting problems really, at least the visible clotting problems aren't that great. It's also possible that there's microvascular thrombosis that we just don't detect and that we help by preventing that. I don't know that anybody knows that. That's the only paper I've seen that actually supports that, but that paper alone did change my thinking, and I have gone, again, to giving heparin even for open ruptures. And I used to not give heparin for open thoracos, and I do that now too. And I don't think it hurts. It may help. Dr. Ard?
A vaccine and maybe unsolvable problem on this topic is the variation within the, what we call ruptured AAA. It sort of compounds, our clinical understanding from research as well as quality measurement. I mean, there's going to be no magic bullet, but are there agreed upon sort of characteristics that are going to be best to try to risk stratify those patients? Since the term is used for anything from tiny amount of extravasation to full-blown.
Yeah, that's a good question. So there are ruptured aneurysms, then a ruptured aneurysm. So the typical definition is blood outside the adventitia of the aorta, and the patient has an aneurysm. And you're absolutely correct. Some patients will have a very small contained hemorrhage that aren't very sick, and other patients will have massive free intraperitoneal hemorrhage, and they behave very differently. Certainly, there are studies that try to compare patients who come in shock versus not in shock, because that's a predictor also. But as far as careful stratification, I'm not sure that is out there. Most of the series aren't big enough really to define things that way. So
we struggle with this with the ARC's inpatient quality indicator on AAA repair mortality. At least it stratifies between unruptured and ruptured. Mm-hmm. So I think it addresses that issue, but my concern is that there's a lot of residual variation in the ruptured.
And there is, and again, the question is whether this is not that common of a problem, 15,000 deaths per year, and that number is probably going down. That number's been, that's a number I've been quoting and seeing in the literature for 25 years, but all the other data suggests that actually the prevalence of aortic aneurysms seems to be going down in Western countries. The screening studies have all suggested that. And more patients are getting their aneurysms detected now because everybody gets imaging for one reason or another. And more patients are having their aneurysms repaired electively because it's considered a less morbid procedure with endovascular repair. So this is a problem that's becoming less prevalent and as a consequence may be a bit more difficult to study. All right, let's break. Thank you.